Thank you, chairpersons and panel. This is a case which I found it challenging. Let's see if you also find it challenging. Let's share this case with you. I just present the findings of this. This is a 55-year-old male patient presented with a non-healing ulcer in foot with comorbidities like diabetes mellitus, hypertension, hyperlipidemia, and he had bypass surgery about 2 years ago, and he also had early nephropathy. So that was another challenge of using a contrast material in this case. This case was discussed by the vascular surgeon and a general surgeon, and they both decided that this needs a amputation because there are distal vessels on the Doppler was not very good, and they were not very comfortable for doing a procedure without having any peripheral arterial lumen. So that was this non-healing ulcer was there for more than a month. So he's got a angiogram which was done just to see what is the status inside. There was a diffuse plaque on the right side, and the left side he has got a long disease segment. Or below knee he has got a severe triple involvement. Doppler, as mentioned, the decreased flow was both the lower limbs and severe impairment in right anterior tibial, posterior tibial, and peroneal arteries. So the question was the small below knee arteries, what should we do? Shall we ask surgeons to come in and take care of this? And surgery is better, but larger caliber arteries, that's what I suppose the surgeons can do much better job, because if there's a long diffuse lesion, the results of the grafts are not as encouraging. This is the still picture of the patient, which you can see that there's multiple lesions and arteries. So I will just show what I have done. The hardware which we used was typical 7 French sheath and guiding catheter, right coronary artery, and balloon. The wires which were used were multiple choice of wires which we used. Sorry, I can't stop it somehow. Wow, let's go for the next one. So he had a diffuse, all the 3 arteries were involved. I was just trying to stop this picture. Why can't it stop it somehow? Sorry. It shows there's some problem with the still picture. And another point was this, when we are using this type of peripheral case, it's always useful to use a DSA system, because then we can reduce the amount of the contrast and you get a very good road map, which other normal cine angiogram you don't have it. So you don't waste too much of contrast. And so he had we managed to open this artery quite well with multiple dilatations, and we have to use few stents, and the rest of the area was taken care alone with the balloon. This is the other artery which you can see that totally diffusely diseased, and later on it fills up. Dorsal spadias artery fills up later. That's good. So this was used, a series of stents were used, and long coronary stents were used in a row to reform this vessel. And later on you can see that on the right there's a multiple reformation of all the 3 arteries. And this was one of the moving pictures before putting the stents. Sorry, there's something wrong with my presentation. And this was before. So just to compare, you can see the arteries we were seeing filled up, and this was before the, just to remind you the picture which were before the presentation, before the deployment of the stents. So this patient's clinical progress is after this stenting, he improved significantly. His ulcer took about 4 weeks, 5 weeks to heal up, and it's very well healed up. And we used Boston and this Cordis stents, multiple. So my understanding is there has been an increased number of reports with the drug-eluting stents in the peripheral circulation. Earlier, it was not considered as a usual accepted technique. So chronic limb ischemia leading to non-healing ulcers or a gangrene needs early restoration of the blood supply. When blood supply cannot reach in periphery, alternative modalities, then surgery should be also considered. Multiple drug-eluting coronary stents as off-label indication can be used for not only in short term but also in long-term gain. There is a need for very long drug-eluting stent. As we get a long peripheral stents, maybe around 10 inches, 12 inches, that kind of stent, if they can be available in drug-eluting because of the long-term patency. Because that's the issue. If you use a long stent in a vessel which is less than 3 millimeter in size, blockage becomes a reocclusion becomes very often. And hopefully that might be the solution. Thank you very much.